Welcome to this presentation. I'm Sue Kressly, owner and founder of Kressly Pediatrics. Thank you for the opportunity to present one of our case studies for the Davies Award. Kressly Pediatrics is a small, independent pediatric practice in Warrenton, Pennsylvania, a suburban community in Bucks County, approximately 20 miles from Philadelphia. I had been in a growing practice for 15 years before I opened a solo practice in 2004. The practice was founded with the vision statement you see here, combining traditional care and modern technology in partnership with families. As such, the practice began with selection of an electronic health record from the onset. In addition, the use of using lean efficiency drove innovation from the beginning. The practice was started using a patient portal synchronized with the electronic health record back in 2004. This was not a commercially available product, but a disruptive innovation that was made specifically for the practice. New patients self-register on the patient portal, setting up a technology-enabled relationship from day one. In addition, watching inefficiencies of multiple handoffs in the pediatric office led to the decision to only have clinical staff in the office. They would perform both clinical and administrative functions. The practice began with one nurse, one MA, and one doctor. The practice has grown to 3 board-certified pediatricians. The staff now includes 4 RNs, 1 medical assistant who also serves as our biller. And yes, that's correct. There are 3 doctors and 5 staff. With a completely clinically oriented staff, this allows for all team members to be empowered to meet the needs of the family, and they are cross-trained, so vacations and illnesses have little disruption on our office workflow. The practice is driven by the quadruple aim. Improving the patient experience of care has been with us since the beginning. Our staff says our practice is much like the sitcom Cheers. It's a practice where everyone knows your name. We have always been dedicated to improving the health of all of our patients, not just those who call us up to receive care. The healthcare environment in our region is one of the few in the country where the capitation payment model continues to exist for half of our patients. The other half is fee-for-service. So we have learned how to manage the total cost of care in order to have a sustainable business model. Commitment to ongoing practice transformation leads the way for improving the work life of our entire practice team. We all value the key roles we play in our family's health and enjoy the relationships we develop and foster. There is significant personal satisfaction in being part of our practice team. The practice has a commitment to the medical home model and, as such, has been recognized as a Level 3 NCQA patient-centered medical home 3 times. Starting with an electronic health record in 2004, Office Practicum, the practice foundation is based on capturing and using data to provide information so that we can increase our knowledge of both our patients and the care we deliver, and ultimately gain the wisdom on how best to deliver optimum care to foster optimum outcomes. The cornerstone of our practice is our dedication to the relationships we form and foster with our families. Whenever we reflect on how to approach a problem, we always include a perspective of the patient and family. All aspects of quality improvement revolve around the PDSA cycle of plan, do, study, and act. Most importantly, we have learned that projects which we plan often don't result in simple adoption when we get to the act stage. We have learned how to be open to adjusting our work and on occasion abandoning projects if we feel that they have not been thought out adequately, we don't have the appropriate technology, or for whatever reason, they're just not quite ready for prime time. For this case study, we will be reviewing our work focused on improving well visit rates. The background that formed the impetus for this project is the evidence-based recommendation from the American Academy of Pediatrics for preventive pediatric health care. Those recommendations are articulated in Bright Futures Guidelines, which are what every expert agrees that each child should have access to in order to have the best chance at a bright future. This includes a periodicity schedule. This is the Bright Futures periodicity schedule for recommendations for preventative pediatric health care. As you can see, it's complex and comprehensive. Understanding the crucial influences of social determinants of health and behavioral health on outcomes, the American Academy of Pediatrics uses the well visit as the anchor for providing comprehensive preventative care to children. Implementing the periodicity schedule in a primary care office can be daunting. We knew that not all our children in our practice were receiving well visits at the periodicity outlined for optimal care. We needed to change our mindset from a reactive one, taking care of patients who called up to schedule a well visit or needed a form filled out for school, daycare, or sports, to a proactive population health management framework. In addition, our major insurance payer has a pay-for-performance incentive based on well care visits for the capitated HMO population in the 3 age bands that correspond to HEDIS measures: the first 15 months of life, ages 3 through 6 years, and adolescence. We were keenly aware that we were leaving money on the table as there was room for improvement on these measures. Our biggest practice problem was that we really had no coordinated efforts to address this problem all year long. In the fall, when we would get our payer preliminary data from them, we would have an annual fire drill during the last quarter to address the gaps in well visits. We often didn't have adequate available appointments to accommodate the patient needs, as the cold and flu season also was getting underway. In addition, in 2017, the pay-for-performance incentive was expanded to the PPO panel, not just the HMO. This more than doubled the covered lives included in this measure. What was our ultimate goal? For all children in the practice to receive well visits at the periodicity outlined in Bright Futures, which provided them with access to evidence-based care. We also knew we needed to completely change our practice mindset from reactive to proactive population health management in all of the care that we deliver to our patients. From the outset, we used a continuous quality improvement format, the iterative PDSA cycles, and within a small practice, it required buy-in from the entire practice team. Frequent reporting back to the group so we could collaborate and improve at our monthly meetings. From our NCQA recognition process, we already had a PCMH quality improvement team, which we used to lead this work. Our eventual goal? 100% of our patient population receiving well visits in accordance with best practice. Initially, we used one of our monthly medical home meetings, which is attended by the entire practice team, to get buy-in, to set a realistic goal, and to prioritize our work. We identified a project owner, agreed on how we were going to tackle this work, and identified technology efficiencies that we could be used. We implemented our plan while monitoring buy-in across the group, and along the way, identified barriers to success and gaps in our work. We measured our performance repeatedly using available technology tools, reported them back at the monthly medical home meeting, and then adjusted our processes and our goals accordingly. This is an overview of our work, starting in 2013, and it continues to this day. I want to point out that this data is really reported over the course of the year, since after age 3, children come in annually for their well visit. While we monitored performance along the way, ultimate outcomes had to be considered over the time frame of the calendar year. In order to capitalize on some low-hanging fruit and build early success, Phase 1 of the project was to leverage existing functionality within our electronic health record. You can see that our baseline was laudable in itself compared to many of our peers, and you will notice steady improvement. We started with a benchmark performance of 66% and were able to improve 9% in Phase 1. We were fortunate in that our pediatric electronic health record, Office Practicum, there is embedded clinical decision support to flag patients who are overdue for a well visit in red, to visually alert the user. This red flag is visible at multiple points of contact in the patient record. For example, on the front page of the patient chart, it shows the last well visit date, and if the patient is overdue, it's highlighted in red. Similarly, nursing staff, when taking a message, has the same visual cue available. When scheduling an appointment for anything, the user gets a visual alert. The first step was really to increase the awareness of the entire practice team. We all agreed that everyone who touched the patient's chart at any point of contact would look to see if the patient was due for a well visit, and then we would make every effort to make that happen. The EHR also comes with functionality to toggle easily between siblings in a family, from any of the children to any of their siblings. We empowered the entire office team to utilize this functionality and at every opportunity identify patients and any of their siblings who were overdue for well visits and use the opportunity to make appointments. The QI team educated everyone about this functionality that already exists in the software, and at monthly medical home office meetings, we reviewed it. This required everyone to buy into the process and act accordingly. We agreed if the family was in the office, we would schedule the appointments for all appropriate children at the point of care. The staff would schedule, and/or the physicians would request the staff to schedule before the family leaves the office. We also agreed that if the care gap was noticed while on the phone with the family, that the staff would schedule the appointments before hanging up. And if physicians noticed the care gap, they would transfer the call for the staff to schedule. Sometimes we touched charts when the patient isn't in the office or the parent on the phone. We all agreed that we would proactively reach out to families when this need was identified. Physicians used the role-based messaging in the EHR to send a message to the nurse department, and whomever claimed the message first would be responsible for making sure the appointment got made. It turned out that we needed to alter our scheduling templates to accommodate more well visit appointments as we identified patients in need of care. In addition, our staff began to suggest at our morning huddle that we turn sick visits into well visits if those patients were due. The staff also started noticing sibling care gaps and leaving reminders in the schedule to close care gaps when one child presented for an appointment. They understood the value of maximizing the opportunity while the family is in front of you. The success of Phase 1 was in leveraging the existing core functionality in Office Practicum. It required increased awareness of the entire team. It required buy-in and ownership from every team member. Its success was, however, limited due to the serendipitous nature of the workflow. It only captured patients who we had some reason to already be in contact with. In Phase 2 of this work, we implemented population management principles and began to proactively implement recalls. From 2014 to 2015, we were able to improve our well visit rates by an additional 10%. Before beginning this phase of our project, we needed to make sure we had measurable baseline benchmarks which we could be confident in, and then identify some surveillance queries which could be used incrementally. We identified the correct technology to perform the recalls, but also needed to establish processes to follow and identify the right people to do this work and give those people protected time to get it done. As we implemented recalls, we needed to prioritize the work and understand both the positive and negative practice implications of our processes. The health IT we utilized during Phase 2 of this project included population recalls, patient messaging, quality improvement queries, all which were available within our electronic health record. The functionality within Office Practicum includes the ability to identify patients who are overdue for well visits in the demographic analysis and recall engine. This data can then be stratified by a number of metrics, including age, payer, and other demographics. After identifying a subset of patients you are targeting, the engine can then be used to choose the recall purpose of Bright Future's preventative care plan and recall for the encounter or well visit. OP also offers an integrated patient message exchange system which can be utilized to proactively reach out to families according to their preference: email, phone, text to cell, etc. The Quality Improvement Calculator also allows for internal queries to be saved and utilized on an ongoing basis. The practice asked for a custom report for well visit rates in our active patient population. We then were able to use this periodically to monitor our performance. Keenly aware that technology is only part of the solution, we knew we needed to have someone available to use the technology. We created a staff role of recall coordinator and gave her a minimum of 2 hours per week of protected time to do this work in the back office, so as to not be distracted by ringing phones or patient needs. Our outlined recall process started the first week of every month, identifying patients overdue using the demographic analysis and recall. Bulk messages were sent via the patient messaging exchange, and 1 week later, the query was rerun to identify those families who didn't respond to the initial outreach and make an appointment. That list was printed, and the recall coordinator sent individual portal messages to families, and if they didn't respond within a few days, a text to their cell. After an additional week, the query was repeated, and the recall coordinator worked the list and called until she got an appointment scheduled. If she was unsuccessful, a series of 3 letters are sent, 2 weeks apart, urging the family to contact the office and discussing the importance of a preventive visit, and eventually assuming the family had found a new medical home, since they were unresponsive to our repeated outreach, and we would make their records available for transfer. It quickly became apparent that we could not tackle the entire patient population at once. We did some work to prioritize. Our highest priority was the payer that rewarded pay for performance, as ultimately we felt that those dollars would pay for our recall coordinator to continue to do this work. We worked on the HMO patients first, since they didn't have a limitation on when during the calendar year the patient could be seen. We also prioritized those age groups where we knew there was a state-mandated form to be signed. Our practice already has pretty great performance with our children under 3 years of age. For the under 18-month age group, we always schedule the next well visit before the patient leaves the office. We always have our schedule in the computer 3 months in advance. At the 18-month and 24-month visits, we have standing orders on the templates to remind us to reach out and schedule those well visits. An additional challenge was that we discovered we were missing new patients in the recall because the query depends on the interval since the last well visit. We needed to find an alternative way to capture those, and we needed to establish a process for aggressively following up with no-show appointments. This is a picture of our well visit template inside OP for the 18-month well visit. The next scheduled well visit according to Bright Future's periodicity schedule is at age 2. But we don't put our doctor schedule in the computer that far in advance. So we put a standing order for the nurse on that 18-month well visit template for 100 days in the future to schedule that 2-year-old well visit. This automatically shows up in the nurse's to-do task list in 3 months, and that will then prompt them to contact the family. This is a screenshot of how we identified those new patients who had not yet had a well visit, so they were more difficult on our regular recall. One of the columns of information available in the demographic analysis and recall is the most recent well visit date. We could sort by blank to capture those patients who have not yet had a well visit in our office, and then we checked old records or asked the family the date of the most recent well visit and placed it in the general notes section of the HR for our recall coordinator to use. Phase 3 of this project revolved around proactive outreach. From 2015 to 2016, we were able to increase our performance an additional 8% to get to 93% of our active patients having well visits according to Bright Futures guidelines. We fine-tuned our recall process and expanded the outreach to include all payers and all age groups. We did proactive future recalls, which we will look at more closely in the next few slides. In addition, we altered appointment availability to better meet our patient needs. The health IT we utilized in Phase 3 includes Office Practicum's capability of choosing a future date to run recalls to better anticipate coming needs, not just care gaps identified as overdue. Our practice releases the provider schedule on the first of the month, 3 months in advance. In part, we do this so that at the 12-month checkup, the family can schedule their 15-month well visit before they leave the office. In the beginning of the month, the recall coordinator would run the recall for the end of the calendar month, which was just released. This identifies all patients due or coming due through that time period. The bulk message exchange through the patient message exchange would inform the families that we are accepting appointments through the end of that month, and we invite them to contact the office for an appointment. This is a screenshot from OP showing where we set future recall date and the integrated messaging capability. As part of our medical home, we periodically do qualitative outreach to families to have a better understanding of how well we are meeting their needs. We included in this survey feedback on preferred time for well visits. We had made some incorrect assumptions of how best to be available to our patients for well visits, and we made scheduling adjustments. These included early morning well visits, immediately after school well visits, and additional availability on school holidays. This necessitated adjustment in our after-school sick visit availability, and we continue to tweak our scheduling seasonally to meet our patient needs. Where was the value derived in all of this hard work, which is still ongoing? Most importantly, our patients are getting better care according to evidence-based guidelines. Outcomes for pediatric preventative care are hard to measure in a short time frame, but we hope our patients become healthier adults, in part because of our commitment to high-quality preventive care as children. Our entire office team appreciates less last-minute stress for office-required well visits, school, camps, sports forums, as most of our patients are now up to date and there are no last-minute fire drills. There is definite return on investment in measurable dollars, including pay-for-performance bonus monies, increased revenue from those well visits, and in addition, the practice often uses high performance to negotiate improved contracts with our payers. This is getting more difficult, but we are among the highest performers in most networks, and this can also mean preferred patient copays and practice tiering. Looking at measurable value, remember this is a small practice. From 2014 to 2016, the practice received over $125,000 in pay-for-performance bonuses. In addition, if we use our 2013 benchmark performance, the additional income generated from increased well visits was almost an additional $200,000, and that's without ancillary revenue from vaccines and additional screenings such as hearing and vision. All told, we demonstrated over $300,000 in additional revenue, which far exceeds the cost to do this important work. Our work is not done. This is a continuous process that we will work to monitor and improve as part of our commitment to using people, processes, and technology to improve the care for our patients and maintain a solid, sustainable business model for our small independent practice. Thank you for your time and attention.